Welcome to The Explainer. Today, we are really diving deep into the world of some pretty serious, unseen invaders. We're talking about 3 specific intestinal worms that, believe it or not, infect millions of people all over the world. Ascaris, which is the giant roundworm, Ancylostoma, the hookworm, and Trichuris, the whipworm. We're going to break down everything: the clinical signs, how you diagnose them, and exactly what the treatment protocols look like.
Okay, let's just start with this statement because it gets right to the heart of the matter. This isn't just for shock value. It's a stark clinical reality that really frames how serious these infections can be. It tells you exactly what's at stake, even in cases that might otherwise seem pretty mild.
So how do these infections actually show up in a patient? Well, a clinical picture is, frankly, a huge spectrum. It can range from someone being completely asymptomatic to a situation that's genuinely life-threatening. Let's start by walking through a classic case presentation.
Now, this combination of symptoms, this whole picture, it should be a major flag for any clinician. That persistent dry cough, that points to the larval stage of the worm migrating through the lungs. And the eosinophilia, that spike in a specific type of white blood cell, is a huge indicator of a parasitic infection. It absolutely has to be on your differential diagnosis.
You know, each of these pathogens really leaves its own distinct clinical signature. With the high burden of Ascaris, you can get a literal physical blockage of the intestine, an ileus. Plus, its migrating larvae can trigger those respiratory symptoms we just talked about, which is known as Leffler syndrome. Then you have Ancylostoma, the hookworm. It latches onto the intestinal wall and causes chronic blood loss, which eventually leads to iron deficiency anemia. And Trichuris, the whipworm, it's often less dramatic, but a really heavy infestation can look an awful lot like colitis. Let's zero in on one of those migratory effects for a second: larva carens. This is not just any old rash. Its track through the skin is rapidly advancing. It's snake-like, or serpiginous as we say, and it's essentially pathognomonic for hookworm. It's a dead giveaway. You're literally seeing a visual clue of the parasite moving right underneath the skin.
Okay, so once your clinical suspicion is high, you need a definitive identification of the pathogen. Let's look at how we build that diagnostic pathway from the more traditional methods all the way to our modern molecular tools.
So the gold standard for diagnosis isn't just one sample, and there's a good reason for that. These parasites shed their eggs intermittently, so to maximize your chance of actually finding one, you use the triple feces test protocol. If you don't collect those 3 samples, the sensitivity of your microscopy just plummets. Following this protocol is absolutely critical.
This brings us to the diagnostic landscape we live in today. You've got 2 main tools. Traditional microscopy is still the workhorse for detecting worm eggs, like those from Ascaris and Trichuris, but identifying them can be tough. On the other hand, for spotting co-infections with protozoa, molecular methods like PCR are now the preferred choice. Why? Because their sensitivity, specificity, and speed are just far superior.
All right, so once we have that confirmed diagnosis, our focus obviously shifts to management. The absolute cornerstone of therapy for these nematodes is a targeted antiparasitic agent.
And the medication of choice here is really clear. Albendazole is highly effective against all 3 of these intestinal nematodes. It's really the backbone of our entire treatment strategy. The dosage, though, well, that's where it can vary.
For example, if you have an uncomplicated Ascaris infection, the treatment is remarkably simple. It's often just a single 400 milligram dose of albendazole. That's usually enough to cure it.
But it's not always that simple. The treatment really requires nuance. Unlike that single dose for Ascaris, both Ancylostoma and Trichuris infections typically need a 3-day course of the drug. It is also absolutely critical to remember that albendazole is a no-go during pregnancy. And when you're treating kids, you have to be extra careful and consult specialized formularies for dosing. On top of all that, you have to think about co-infections, because something like giardiasis can seriously complicate the whole picture, especially in children.
So, let's zoom out now. Moving beyond just treating the individual patient, every single diagnosis is a data point in a much larger epidemiological story. And this is exactly where clinical practice and public health intersect.
A key concept here is the reportable disease. For certain infections, Let's take trichinolysis, which is also caused by a nematode. Clinicians are actually legally required to report cases to health authorities. This data is absolutely essential for surveillance systems to spot outbreaks, trace them to their source, and put control measures in place.
And this is what that source tracing actually looks like in practice. Using trichinolysis again as our example, a really detailed dietary history, the anamnesis, is paramount. The clinician turns into a bit of a detective, asking pointed questions about eating undercooked meats like pork or game, and asking about travel to endemic regions. It's clinical detective work, and the results feed directly into public health action.
Finally, let's circle back to where we started in a way, the risks and the long-term consequences. Because effective management isn't just about curing the immediate infection, it's about preventing the lasting impact, or what we call sequelae. You can see here that the major complications for each of these pathogens are directly tied to the worm burden. For Ascaris, a high burden creates a very real risk of a mechanical bowel obstruction. For Ancylostoma, the danger is a profound, debilitating anemia from all that chronic blood loss. And for Trichuris, a severe infection can present as a painful, symptomatic colitis. These are not trivial outcomes.
And here's an emerging area of concern that's really fascinating: post-infectious syndromes. We see this a lot with protozoa like Giardia. The principle is that even after an infection is totally cleared, it can trigger these long-term conditions like irritable bowel syndrome or even chronic fatigue, sometimes years down the road. It's like the initial infection leaves behind a lasting immunological or physiological scar.
So this leaves us with a really critical question to ponder. These nematodes are absolute masters of stealth. For every single dramatic case that we diagnose, how many more are out there that are silent, that are subclinical? It really forces us to confront the true, hidden burden of these unseen invaders, and to think about the scale of the diagnostic challenge that's still ahead.